Good afternoon, everybody, and welcome to Grand Rounds. Today I have the pleasure of introducing Kathleen O'Connor. Kathleen is a licensed mental health counselor and a certified eating disorder specialist, and she has kindly accepted our invitation today to provide us with a review of weight, health, and eating disorders. And please join me in welcoming Kathleen. Thanks.
Thank you very much. I'm very excited to present to you all today on eating disorders. This is a very valuable topic. And I've tweaked it a little bit from the original presentation. However, the objectives are the same. So I'll introduce myself briefly. Again, my name is Kathleen O'Connor. I'm a licensed mental health counselor in the state of Iowa, in addition to being a certified eating disorder specialist, which is a designation from the International Association of Eating Disorder Professionals regarding the additional clinical and educational expertise in the field of eating disorders. I'm happy to chat about any of this or answer any questions after the presentation as well. And again, I'm presenting on behalf of the Eating Disorder Coalition of Iowa, which seeks to spread awareness and education regarding eating disorders throughout the state. And I am here to provide a broad overview of eating disorders and weight-inclusive care. I'm going to be providing a lot of information and data. For those of you interested on the fine details of some of those slides, I've provided an extensive set of references as well. So as the previous slides stated, I do not have any disclosures to report, and my perspective really comes as a therapist, informed by my experiences treating the eating disorder population. So while I'm not a medical professional, my clinical experience in hospitals and residential treatment settings, in addition to my current work with outpatient therapy, allowed me to work on interdisciplinary treatment teams with medical professionals, which you'll soon see is critical in the treatment of eating disorders. Eating disorders are mental health conditions which can at times have serious medical complications and consequences, so it's instrumental for medical providers to be aware of what we're working with. Our objectives for today will be providing an overview of eating disorder diagnoses and what those might look like. We'll be discussing how weight stigma can contribute to eating disorders and explore a weight-inclusive approach to healthcare and the treatment of eating disorders. So let's get into it. What are eating disorders? It's a class of behavioral, psychological, and physical health diagnoses in which one's relationship with food and body are disturbed. So the data suggests that approximately 30 million Americans will have an eating disorder in their lifetime. It's approximately 10% of the population. And within that, less than 6% of people with diagnosed eating disorders are medically diagnosed as underweight, which means that the people that you might be encountering who do have eating disorders are not what you would stereotypically expect. Anywhere from 28 to 74% of the risk of eating disorder development is through genetic heritability, but there are a number of different factors and kind of puzzle pieces that contribute to the development of an eating disorder. Eating disorders are the second deadliest group of mental health disorders, surpassed only by opioid use disorder, and statistically one person dies every 52 minutes from the complications of an eating disorder. That can be some of the mental health comorbidities such as suicidality or the medical complications. And eating disorders are best conceptualized through a biopsychosocial model, which means that there are a multitude of traits that can contribute to the development of an eating disorder. No one trait will determine if an individual develops an eating disorder, but it will make someone more predisposed to developing one. So the biological or genetic risk factors include a family history of eating disorder, family history of dieting or overeating. Personal history of dieting is highly indicative of the development of an eating disorder. High parental demands, parental substance use disorders, as well as type 1 diabetes or even being a twin. Psychological influences, perfectionism, novelty-seeking traits, a history of trauma, body image dissatisfaction, experience of bullying or stigma, and the personal history of any sort of mental health comorbidities, anxiety disorders, depression, OCD, etc. And then rounding out that third facet of the biopsychosocial model would be the social context in which we live in. Our society is highly focused on a thin ideal, And diet culture is prevalent. So really there are tremendous amounts of messaging regarding changing body shape and size that would also contribute to the development. Again, it's not one thing that creates an eating disorder, but there are kind of a complex constellation of events. Who gets eating disorders? Anyone and everyone is likely to develop an eating disorder. Quite frankly, it's kind of surprising when we look at the factors that contribute to it that more people don't have them. Eating disorders don't have a look. So it's not just kind of that stereotype of a thin, rich, affluent woman with anorexia. Really, we're working with anybody. And my hope throughout this presentation today is that we can move away from that stereotype and be more mindful of the various presentations of eating disorders. Again, given that only 6% are clinically underweight. So eating disorders affect people of all sizes, genders, races, etc. Women are twice as more likely as men to develop eating disorders, but that doesn't mean that men can't have eating disorders. And their presentations may look similar, and they may look different. So we'll move over to diagnostic criteria, starting with the most commonly known or commonly researched eating disorder, which is anorexia nervosa. And again, just for expectation setting purposes, I don't expect anyone to leave this presentation understanding the fine details and nuances of eating disorder diagnoses, but rather to be able to loosely identify and differentiate between them. So as you can see here, anorexia has a number of subtypes. I don't expect you to be able to suss out if it's restricting type or binge purge type, but really to understand the overarching theme here of anorexia, the hallmark trait would be the restriction of energy intake and the intense preoccupation with body image and thinness. Currently in the DSM, anorexia has a BMI limit to it. So this is why we're not seeing a lot of traditional diagnoses of anorexia nervosa. At this time, the cutoff for anorexia needs to be a 17.5 BMI or lower in adults, or 85% target body weight or lower in children or general population. The hope within the eating disorder community is that this is eventually eliminated due to just the prevalence of various forms of atypical anorexia within the population. So when you're working with somebody with anorexia, outside of the significant malnutrition and weight loss that you will see, you'll see an intense fear of gaining weight, an altered perception or distorted body image. A persistent lack of acknowledgement of the seriousness of one's low weight is also one of the hallmark traits of anorexia. When we're working with a malnourished brain, they're often not going to see the problem. And then in combination, that distorted body image is going to make it hard for them to identify that this is serious. So we see a lot of our research for anorexia nervosa being prevalent in the field because this is the most homogeneous sample size. With anorexia, we're typically seeing co-occurring anxiety, a high drive for perfectionism. A lot of the folks with anorexia are going to have the same personality traits. And a lot of the data as well is fairly homogeneous. References to malnutrition as well as, historically, even going back to the Minnesota starvation study, it's generally easier to identify what's going on with anorexia nervosa compared to some of the other eating disorder diagnoses. And then within anorexia, we have these two subtypes. So restricting type would be more of that typical or stereotypical type that you would see of restricting calorie intake, restricting food groups, really, really limiting our energy needs in service of weight loss. And then we also have the binge purge type. So that can come up with, again, the restriction element, but we might see binging due to that deprivation at times, as well as purging, and that can take place through self-induced vomiting. Oftentimes this will also appear through compulsive exercise as well. So the main takeaway for anorexia is that we're seeing restriction. Here are some of the signs of restriction and medical complications that you may see if somebody is struggling with a restrictive eating disorder. Some, all, or none of these can occur within the context of an eating disorder. And this is where it's a little bit tricky because everyone is different. I have had experience working in residential treatment where we're working with highly weight-suppressed individuals, BMIs of 13, and their labs may be completely normal. We are seeing a lot of hair loss and a lot of other symptoms, but we can kind of pick and choose, I guess, when it comes to how these present. And then throughout the weight restoration process, these things can shift. We can see lab abnormalities come up, the vitals and things can shift as well. So patients with eating disorders may not be coming to you with the eating disorder being the chief complaint, and it's important to identify if we're seeing a lot of these signs and symptoms, this may indicate that an eating disorder is present. Next, in terms of our diagnoses, we have bulimia nervosa, and this is really coming out through repeated episodes of binge eating and purging. So the differentiating factor between anorexia nervosa and bulimia nervosa would be that while restriction may be present, we're seeing primarily binge and purge behavior here. In terms of meeting the diagnostic criteria here, we're seeing binge eating and compensatory behaviors. Compensatory behaviors can take place through self-induced vomiting, laxative diuretic use, fasting, excessive exercise, and even misuse of insulin. We're seeing those occur weekly for at least 3 months. And again, there's also a body image component here when we are working with bulimia nervosa. Some signs that we might be encountering a patient with a binge or purge pattern would be malnutrition. However, it is less severe than with anorexia nervosa and the acute restriction occurring there, but the medical complications and risks are far more frequent with bulimia nervosa, depending on the method of purging. Specifically with self-induced vomiting, we're running the risk of esophageal tears, fluctuations in electrolytes, etc., that really put somebody more at risk than they would with restriction, simply because the body can acclimate to restriction a little bit more easily. Doesn't mean it's good. It just means that's what we see in the population. In acute episodes of bulimia nervosa, you might also encounter a patient with swollen cheeks due to the purging. Purging can occur in different ways, though, so we're also seeing complications from laxative abuse, significant amount of GI distress and bowel distress there. Next, we have binge eating disorder, which is the most commonly diagnosed or treated eating disorder currently. And binge eating disorder is recurrent episodes of binge eating without any of the compensatory behaviors. Oftentimes, folks with binge eating disorder are going to be feeling very distressed and very out of control with this behavior, and they're far more likely to come to a provider and say, this is something that I am struggling with. It's also important to differentiate when somebody is reporting that they suspect they have binge eating disorder. Is it an objective or a subjective binge? Oftentimes, binge eating can occur following a state of deprivation. So if somebody has, for example, skipped breakfast and lunch that day and then eaten a dinner that might be twice the normal size, that would be a subjective binge, and that is typically in response to that restriction or deprivation. Whereas objective binging, while there aren't necessarily qualifiers for it, you'll kind of know it when you see it. That's the really out of control or aggressive feeding pattern that we have seen here listed in the slide. And we're seeing marked distress, on average, binge eating occurring once a week for 3 months, and not associated with any other eating disorder behavior. One of our newer eating disorder diagnoses is avoidant restrictive food intake disorder, or ARFID. Oftentimes, this can present in children and adults, as with any other eating disorder diagnosis, but it can present in a number of different ways. At times, this can look like extreme picky eating, so only eating one food group, one type of food, one kind of genre of food, eating foods of all the same color or texture due to sensory issues. But typically what you're going to see is, again, somebody kind of falling off of the growth curve that you would typically expect for them, or an adult failing to meet growth markers, as well as marked nutritional deficiency. The difference here between ARFID and anorexia nervosa is that typically these patients will know that it's a problem and will recognize the need to gain weight. They'll understand that this is not related to body image. This might be due to simply a lack of interest in eating. Some people are just not wired to be focused on food, or are not in tune with their hunger and fullness cues, so they may just completely not be in touch with that. maybe sensory sensitivity. There's often a high overlap between ARFID and autism spectrum disorder due to the sensory component. And ARFID may emerge as a fear of adverse experiences. So I've worked with a number of clients who have developed ARFID in response to an episode of choking and then fear of subsequent choking, as well as a fear of vomiting, which is a fairly common phobia. It doesn't mean that you will then develop ARFID, but I think it's the degree to which the impairment occurs is really what helps us identify, is this a diagnosable eating disorder? Additionally, with ARFID in more acute cases, you will see a reliance on tube feeding or oral nutritional supplements, depending on the degree of restriction and significant interference with their level of functioning. Finally, we have OSFED, so other specified feeding and eating disorder. And within the context of the DSM, this is kind of our catch-all. If we're not sure, if it's not really checking the boxes for any other eating disorder, this is where typically things will lie. And this is one of the more commonly diagnosed eating disorders, simply because the other ones are fairly stringent. With anorexia, we need to meet a BMI requirement. With bulimia, binge eating, we need to meet a certain pattern or number of behaviors to make it quantifiable. So a lot of patients are qualifying for OSFED when we're still seeing that significant impairment in social functioning, occupational functioning, that psychological distress, but we may not be purging as frequently as the DSM would require. A lot of different presentations for this might include atypical anorexia, which I will get to in my next slide, purging disorder, which would be purging in the absence of binging or restriction, as well as night eating syndrome, which is similar to binge eating. It's occurring typically in the evenings. It's causing marked distress in patients. And any of these just kind of, there's definitely disordered eating and eating disorder present, but it's not quite falling into the other categories. So when in doubt, and if we're kind of seeing this in isolation, we would typically go with an unspecified or other specified feeding and eating disorder until we can do a more thorough assessment on a patient to determine what's going on. But in terms of medical presentation, I know this can kind of seem like, oh, well, if we don't know, we'll just put it in OSFED. The medical complications can be just as severe as in anorexia nervosa and bulimia nervosa. Simply because of that weight requirement, I mean, eating disorders can occur at any weight, and I think the medical complications can be just as severe. Which leads us to a discussion of atypical anorexia. So this is a situation in which all of the criteria of anorexia are met, yet the individual's weight is within or above the quote-unquote normal range, despite significant weight loss. So again, medical complications are going to be just as severe, and typically these are where our anorexic patients are going to be, because only 6% of our individuals with eating disorders are markedly underweight. So this is our greatest growing eating disorder diagnosis, and often results in a treatment delay simply because people don't recognize this as a serious problem, and because of the prevalence and normalization of dieting and weight loss within our culture. Through the lens of an eating disorder professional, weight loss should always be questioned and explored rather than praised. I think of now as we get into the holiday season, seeing family members or even kind of coming up on this idea of New Year's resolutions, people are so focused on weight loss and commenting on others' bodies. And folks can often be praised for losing weight. However, this can be very indicative of many health concerns and problems, including the development of an eating disorder. From my experience in treating folks with eating disorders, I have seen cases in which clients have fluctuated or lost up to 100 pounds within a short period of time, a few months to a year, and often go underdiagnosed or missed by medical providers simply because people thought that that was necessary, appropriate, or normal, when in reality, this was a response to acute restriction and was causing significant psychological distress. It took an eating disorder provider at that time to say, this is not, quote unquote, normal weight loss, this is very serious. And the medical complications associated with that were just as serious as anybody with a highly suppressed BMI or weight, as we would see in anorexia nervosa. So this leads us to our next objective, talking about fat. Now that we've covered the diagnostic criteria for eating disorders, we're going to transition into how weight stigma can contribute to the development or the maintenance of an eating disorder, and how eating disorders can become more severe because of weight stigma. There's a commonly held belief in our society that weight is a choice or a behavior, when in reality it is not. And that can really occur and is pretty evident throughout the language used. The Latin derivative of obese means to eat oneself fat, and that really places the responsibility for the perceived problem on the individual, rather than recognizing that body diversity exists and that weight may not be the problem. So when we use the word fat, I use that word as a neutral descriptor to describe someone's body. However, not everyone does, especially when we're talking to a patient population. We're definitely going to want to follow our patient's lead rather than just calling them fat. So if they're choosing the term larger bodied, etc., let's honor that, because this language may be seen as offensive to patients. Looking at this from an eating disorders prevention lens, weight stigma is one of the greatest risk factors for the development of an eating disorder, and weight stigma prevents people from seeking treatment for their eating disorders. They can often feel afraid or ashamed to talk to providers about this simply because they might be seen as not valid, because their weight is quote unquote normal. So in terms of how we can prevent this, we really just want to be mindful and educate ourselves on weight stigma and how this might contribute to the greater context and culture of the development of an eating disorder. So what is weight stigma? Despite the preponderance of evidence that exists that one's weight is primarily the result of genetics, biology, our society frequently views individuals in larger bodies as being responsible for their size. So this comes through so many messages from the media regarding anti-fatness, and it has created an environment in which individuals in larger bodies are seen as lesser or unworthy because of their size. Weight is often seen or perceived to be the direct result of choice or action. So many in society feel it is permissible to discriminate, shame, or punish those in larger bodies. So this is really what we're talking about when we talk about weight stigma. It's all of these discriminatory acts and ideologies targeted intentionally or unintentionally, inadvertently or advertently toward fat individuals. And there are a number of consequences to this. It results in psychological distress, internalized stigma, increased stress, binge eating. It decreases the motivation and frequency of exercise, and it is associated with higher levels of stressful life events. The final point there is the bidirectional experience of weight and weight stigma. So the experience of weight stigma in an individual leads to weight gain because of the stress, or inhibits weight loss through increased eating and other biobehavioral mechanisms. So it kind of gets people stuck on this feedback loop of, I am completely isolated and stigmatized here. My only mechanism of coping is through food, and it kind of just creates this vicious spiral. There are a number of consequences to weight stigma as well. In terms of health, and we can see an exhaustive list here. When the research controls for other factors, we can see that weight stigma itself creates added stress, which in turn creates a number of health consequences. So there's a wealth of evidence here. If anyone is curious, I would encourage you to dig a bit deeper into the references. But it is quite interesting to see if we're kind of removing all the other factors and we're looking at what is the result of the stress that we're experiencing. We are seeing a lot of negative health outcomes. This shows up in healthcare as it does everywhere. The rates of weight bias mimic in the healthcare setting mimic the rates seen in the general public. Physicians are the second highest group reported to stigmatize. This is the one fact here on my list that I did not have the time to kind of dig into, but I will follow up to see who the first highest group is. Very curious about that. And in a number of studies, we see a lot of bias reported by physicians. There are some assumptions that overweight patients are awkward, unattractive, ugly, not compliant, weak-willed, sloppy, lazy, less worthy of respect, a greater waste of time, and physicians tend to spend less time and build less rapport with these patients. And bias can be implicit. We may not fully know that we are experiencing this type of bias. Harvard has a lot of really handy implicit bias tools to help us understand, is there some subconscious or unconscious bias occurring within body diversity. But at the end of the day, the consequence of spending less time and building less rapport with a patient is often not accurately understanding your patient or the context in which their problem exists. For example, if we assume a patient's chest pain is a result of their weight, we may miss the mark on other health issues that may be present and potentially worsen the outcome. So it makes sense that prescription weight loss occurs in this society and that weight loss is encouraged and praised essentially universally. Oftentimes, folks in larger bodies are prescribed weight loss to quote unquote improve their health without a real understanding of what specific markers we're looking for in order to monitor that. Discussions of weight loss, specifically in medical settings, are a known trigger for disordered eating, and this occurs throughout the size spectrum. So even folks in smaller bodies can feel triggered, especially when we're predisposed to an eating disorder, to participate in further disordered eating. This comes up specifically with scales and whatnot. We can get into more examples later in the presentation. There's a wealth of evidence supporting the belief that weight loss is a highly ineffective intervention. Up to 95% of individuals gain the weight back within 2 to 5 years, often starting immediately after the restriction or the diet might end. There's a long history of research showing this pattern dating back decades. And one of the things that's not typically talked about is that 66% of people will end up gaining back more than their starting weight. And this is really a self-preservation mechanism within the body to prevent any sort of famine or any sort of deprivation in the future. Or typically these weights trend higher and higher the more dieting one participates in. Dieting is predictive of future weight gain in adolescent and adult samples, and that is a very, very large red flag there. I think with any sort of dieting, especially in adolescence, that's highly indicative of the development of an eating disorder. And again, it goes back to, like, will this cause an eating disorder? Maybe yes, maybe no. We can't say that concretely, but it would be predictive of a high risk factor. We're also seeing binge eating and overall increased eating habits the more one participates in weight loss efforts or dieting, and that is also a great risk factor for eating disorder development. Some of our handy-dandy new weight loss methods, medications, and again, this goes back decades in terms of the research regarding weight loss medications, and then more recently with the Ozempic era that we're currently in. Weight regain is also reflective of dieting regain. So we're seeing pretty consistent results regardless of the methods we're using, that weights will typically trend back to baseline when dieting stops. Bariatric surgery is also highly controversial. Weight regain still occurs and high rates of eating disorders in post-surgery patients. I would also argue this occurs in pre-surgery patients who are predisposed to disordered eating or eating disorder behaviors, that often go missed or undetected in their psychological evaluation because they're not working with an eating disorder provider. There are often health-harming side effects as well related to bariatric surgery that aren't fully, I think, laid out or mapped out to folks in their informed consent. And I understand. I think a lot of these patients are kind of told that bariatric surgery is our only solution. This will solve all of our problems. It's kind of laid out to be a panacea, and the reality is it does have a number of consequences as well, not only to mention the weight regain still occurs. So we have all of these diets, all of these prescriptions, all of these solutions offered, but the end result is weight cycling. So typically, folks who participate in intentional weight loss will often gain that back and kind of fall into this pattern of frequent weight loss followed by weight regain. This, again, is associated with obesity severity. So the more we diet, the more likely our weight or kind of baseline weight is likely to trend up. And the greater number of attempts to lose weight are indicative of worse outcomes. There's plentiful research connecting weight cycling to poor health outcomes that were previously attributed simply to weight or BMI. So really, I think the up and down of the body, kind of gaining weight and losing weight, is harmful to one's overall health. And as we can see here, independent of BMI, we're seeing chronic inflammation, increased risk of hypertension, risk of endometrial cancer, greater odds for sleep apnea, increased risk of metabolic syndrome, and a higher frequency of weight cycling is related to higher risk of cardiovascular disease and death. Which begs the question, what are the risks? What are the benefits for our health? Is prescription weight loss worth it? At this point, we don't have the data to support that weight loss is an effective intervention. We can't guarantee weight loss maintenance. We can't guarantee that weight loss will result in improved health and reduced disease risk in the long term. And individuals who lose weight, we also can't guarantee that they will be as healthy as their thinner peers. What we do know is that intentional weight loss can trigger an eating disorder, and improved metabolic markers can exist and are a result of behavior change, not weight loss. Moving into objective 3, what is our alternative approach here? If telling people to lose weight has proven to be ineffective time and time again, and only works in 5% of the population, what are we looking to do? I think instead the most important thing we can do is to promote a weight neutral or weight inclusive approach. So as we can see in the red here, the weight-centric approach of just lose weight is really a futile cycle and is not beneficial to health outcomes. But when we're talking about a weight neutral approach, we are really reducing the likelihood and prevalence of eating disorders. So health promoting behaviors can exist outside of the number on the scale. What does it look like to practice weight inclusivity? We're looking to create an environment that is size inclusive. So that includes seating, equipment, the weight sizes that we have for the equipment that we're using. That can be blood pressure cuffs, gowns, and having those readily available. Discussions of diet are eliminated or deferred to a dietitian. Patients are allowed to not be weighed, or patients' weigh-ins are not necessary or standard practice. Care is given consistently and for all, and body diversity is not seen as a disease or problem that needs to be fixed. I think the weight part often creates a little bit of questioning or pushback, and I think when we really think about it, what do we need that weight for? What do we need the number for? And I encourage all eating disorder patients to be mindful of that, only being weighed if medically necessary, unless it's with a dietitian or an eating disorder specialized provider. Oftentimes this can be a highly triggering or shameful experience, regardless of our eating disorder diagnosis. A recent example I encountered with a patient was they had sliced their hand and had to go to the ER for stitches. And in triage, they were asked to obtain a weight. And this is not a patient in a higher body. This is a patient who's struggling with a highly restrictive eating disorder. And that was so frightening for them to know that weight and to experience that anxiety that they ended up leaving the emergency department rather than getting the care that they needed, simply because there was so much pushback on obtaining their weight. And I understand the healthcare system that we exist in at times requires that, but I think it's worth considering, like, do we really need this, or are there ways to work around this to be more weight inclusive? One of the weight inclusive approaches that is highly recommended is called Health at Every Size. This is also a book published by Lindo Bacon that helps us understand the principles of the movement. It's aimed at ensuring more equitable access to treatment for individuals, regardless of size or health status, because health is going to inherently look different for everybody. Not everybody is going to be capable of taking X amount of steps or doing X amount of things, or even having the same blood pressure, cholesterol levels, et cetera, of everyone else. So we're really focusing on addressing health and disease rather than weight on an individual level, reducing stigma to reduce patient avoidance of healthcare. There's a tremendous amount of avoidance of healthcare for eating disorder patients, regardless of diagnosis. There can just be so many pitfalls and questioning of, like, is this a valid concern? What is going on here, and that fear of, are we going to focus on weight rather than some of the other problems that an individual may be experiencing? And really what we want to do is support behavior change. Weight is not a behavior, so how can we support folks in advancing their health goals? Some of the pillars of HAES, or health at every size, include weight inclusivity, respectful care, health enhancement, eating for well-being rather than dieting, and life enhancing movement rather than exercising for the purposes of solely weight loss. All of these things in combination can improve health outcomes. As we can see here, weight-neutral interventions not only reduce weight stigma, they reduce instances and episodes of binge eating, improves diet quality, mental well-being, quality of life. We're improving clustered cardiometabolic risk factors regardless of weight loss. So a person's weight, even in a higher weight body, can remain the same, and we're still seeing cardiometabolic improvements and increasing total cholesterol, LDL, triglycerides, and systolic blood pressure. So the data is fairly clear in the importance of behavior change versus weight loss. Health improvements are clear without any weight loss. And this is a study from Matheson and colleagues. So we're seeing BMI here, as well as improvements in health markers. So really we're looking to reduce smoking, eating more than 5 servings of fruit and vegetables a day, drinking alcohol in moderation, and engaging in physical activity more than 12 times a month. I feel like some people can be challenged by some of those markers. We need to take X amount of steps per day, or this new initiative said that we need to work out however many times per week. But I think really what we're looking for is trending toward an ultimate goal rather than setting an expectation that might be unrealistic, and therefore we lose buy-in for overall health for a lot of patients. So we've gone down a health at every size rabbit hole, and I think this kind of complicates how can we better treat eating disorders. But I think a weight-neutral approach helps everybody, regardless of the eating disorder diagnosis or the type of eating disorder, whether you're in a smaller body or a larger body. We really want to be mindful of promoting that weight-inclusive care. But if you're seeing somebody in your encounters that you suspect has an eating disorder, what can you do? Well, the first steps to eating disorder treatment include establishing a treatment team. If you, as a medical provider, as a dietitian, as a social worker, suspect that somebody has an eating disorder, my first and most important recommendation is never operate alone. So establishing an interdisciplinary treatment team that includes a primary care physician, an eating disorder therapist, as well as a dietitian is critical in terms of early intervention or late intervention. We need that care. Establishing a level of care if needed. I think with more of the acute presentations that I had outlined earlier in anorexia and bulimia, as well as with OSFED and binge eating disorder and ARFID, all the diagnoses, we want to make sure that we're assessing if medical stabilization is needed. There are a lot of complications that we can face in the treatment of an eating disorder, so making sure that we have a clear care plan outlined. In collaboration with the dietitian, we want to establish if and how much weight is suppressed, set realistic goal ranges to be reassessed every 3 to 6 months, nutrition rehab, and most importantly, psychological progress cannot occur until renourished. Oftentimes our eating disorder patients will say, maybe I'll just go to a therapist because they're afraid of the dietitian or afraid of the doctor. But really, a malnourished brain is not going to be working effectively for that therapeutic or psychological progress. So that's where it's really key for primary care physicians, any sort of medical provider, and dietitians to collaborate to make sure that we are stabilizing eating disorder symptoms and renourishing them so that they can effectively participate in the goals that they want to. So what does that mean? If we have a very acute presentation of an eating disorder, we have to figure out what level of care they go into. On the left side of the screen, we have our more acute levels of care. So we're looking at inpatient, that could be medical hospitalization or behavioral health hospitalization, all the way down to the right side, which is outpatient treatment. So we're really removing the support and structure and increasing client autonomy as we move to the right hand of the screen. The state of Iowa is tricky, though, because we do not have any inpatient eating disorder units. So that would be an out-of-state option for clients unless they need medical stabilization on it within a hospital system. So we're looking at complete food refusal, high medical complications, potential concerns for refeeding if we're in the inpatient setting, And if the behaviors and medical complications still remain severe, we would be looking into a residential treatment environment or partial hospitalization program. The only partial hospitalization program that exists in Iowa right now is the University of Iowa. Resources are very scarce, which creates a problem for outpatient providers like myself. My caseload is fairly acute in terms of supporting people and getting the resources that they need. So it is very, very important that we are highly collaborative in the treatment of an eating disorder. Intensive outpatient programming also doesn't quite exist in Iowa unless it is virtual. So that is why that team approach is so necessary in order to manage a case in the case of an eating disorder. What are we looking for in terms of progress with an eating disorder? Weight restoration is going to be key, as well as stabilization or cessation of eating disorder behaviors. So if we're working with bulimia nervosa, we're looking for cessation of binge purge. If we're working with anorexia, we're looking for cessation of restriction. And that will show up with all of these other progress indicators. So we'll see improved energy levels, resuming their menstrual period if applicable. At times that can be an indicator of malnutrition, and it was at one time an indicator or kind of a criteria for anorexia. No longer applicable in the DSM, but very important for hormone health. Vitals, temps, labs in normal ranges. We're looking for adequate sleep, social functioning, GI functioning, making sure that we're kind of resuming normal interaction. And then kind of at the tail end of the recovery process, we're seeing improved body image. But the trajectory of eating disorder recovery can often be quite long. It is a month-long process, at best, years-long process in our most difficult times, and recovery looks a little bit different for everybody. So it is very important that if we are encountering somebody with an eating disorder, that we are connecting them with services that specialize in the treatment of eating disorders rather than more of a generalist, dietitian, therapist, etc. Again, eating disorder specialized medical providers are like a needle in a haystack. I think when we're talking about eating disorders, they are quite prevalent, but folks who specialize in them are pretty hard to find. So if you are in need of any resources, the Eating Disorder Coalition of Iowa has plenty for you. We offer a free consultation group the third Thursday of every month. That is open to any provider, regardless of discipline, to join. We offer educational events throughout the year, and we offer a weight-inclusive provider directory in addition to resources for therapists and dietitians within the state. So I'm a fast talker. I threw a lot of information at you. I want to thank you all for your time today. If you have any questions, I'm happy to answer them. And I also have my contact information here if it's ever necessary. But I'm going to stop sharing my screen if that's okay and see if any questions are coming up. We've got silence, so I don't know if that means we don't have questions, but I'm happy to hang out for a little while if anything comes up. Oh, okay, we've got a question in the chat. I've been seeing quite a few patients with eating disorders. Okay. Oh, thank you, Sarah. That is such a valuable resource. I will absolutely add your name to the directory. Okay, well, I will take that as a lack of questions. But again, if anyone has any questions, my contact information is available on the slide deck. And I'm also available, my contact information is available on the Eating Disorder Coalition of Iowa website. So thank you so much for your time this afternoon, and take care.